Welcome to our webinar today. My name is Tracy Cook with Sachs Healthcare Communications, and I'll be your webinar producer for today's event. Before I introduce our moderator, Kimberly Kelly, and our speaker, Nicole Kupchuk, I'd like to show our audience how to send questions and comments. You have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of the GoToWebinar control panel. You may send your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. You can also download a copy of today's presentation in the handout section of the GoToWebinar control panel. For those that may be using a slower internet connection today, please turn off or close down any other computer applications, programs, or internet applications you have running to hear the session today. Our moderator today is Kimberly Kelly. Ms. Kelly is currently a clinical consultant at Baxter Healthcare and has been a critical care nurse for almost 15 years. She has been a very active member of the American Association of Critical Care Nurses and is currently a regional board member. In 2015, Ms. Kelly wrote a widely used self-learning module for her use in hospital facility on Cold Blue. Welcome, Kimberly.
Thank you. Good morning or good afternoon for some of you. Thank you, Tracy, for that very kind introduction. The title of today's webinar is Cases in Capnography, So Much More Than Ventilation. Speaking today on this very timely topic is a colleague and friend of mine, Nicole Kupchuk. Nicole has practiced as a critical care nurse for over 20 years. About 15 years ago, she began working at Harborview Medical Center, a change that spurred an interest in resuscitation. Shortly thereafter, Nicole was part of a multidisciplinary team that was one of the first in the United States to implement therapeutic hypothermia after cardiac arrest. As part of this effort, Nicole was responsible for protocol development and has published numerous papers on this topic. In 2013, Nicole founded Nicole Kupchuk Consulting and Education. Nicole has the following disclosures. She has disclosed the following relationships as being on a speakers bureau with Stryker and La Jolla Pharmaceuticals, as well as being a consultant for Stryker and Baxter Healthcare. Continuing education for nurses, respiratory therapists, and EMS professionals. This educational activity has been approved for 1 contact hour. A link to obtain the CE credits will be available at the conclusion of the webinar. The accreditation statements are as below, and support for this educational activity has been provided by Stryker. Nicole, are you ready to get started?
I am. Good morning, everyone. I want to say a big, huge thank you to everybody for joining us. As we all know, the last few weeks have been really challenging in healthcare. So I just want to say to everybody, hang in there. We're all going to get through this. But wanted to join, just welcome everybody in joining today's webinar, which is titled Cases in Capnography, So Much More Than Ventilation. So we're going to talk about how you're going to use capnography as a marker of ventilation, but I'm also going to show you how you can use it in cases of VQ mismatch. So we're going to talk about, again, cases of normal and abnormal VQ relationships. I'm going to discuss capnography as an indicator of fluid responsiveness, which is actually a really interesting thing. Most of the research is in intubated patients, but with advanced airways, but I want to show you this. And then we're going to talk about how you integrate capnography into resuscitation. So I want you guys just to kind of think clinically. So what are some reasons, either in the pre-hospital EMS arena or in hospital, what are some reasons we would use capnography? And just kind of think about the patients that you take care of. But in general, it is the gold standard for endotracheal tube placement. You can use the color change devices, but far more predictive of proper airway placement in the lungs versus the gut would be continuous waveform end tidal CO2. We definitely are using it when we're providing moderate to deep sedation for procedures. I'm going to show you how you can use it in different metabolic disorders, how you can use it in asthmatics and COPDs who have restricted airway disease, to understand if your beta agonists are working. And then we're going to talk about how you use it definitely in fluid responsiveness and then also cardiac arrest. So a couple things just to get everybody on the same page. So first of all, there's what you exhale, and that's what we're going to talk about today in the form of end-tidal CO2. A normal end-tidal CO2 is about 35 to 45 millimeters of mercury. So again, that would be normal. Then there's what you measure in the blood, and that's your PaCO2, and we refer to this as perfusion. So a normal PaCO2 is 35 to 45 millimeters of mercury. Now, I will say something, I want to say this super clear. Your PaCO2 physiologically will always be higher than your end-tidal CO2. So I'm going to say this one more time just so we're super clear. Your PaCO2 physiologically will always be higher than your end-tidal CO2. But in normal VQ perfusion ventilation perfusion relationships, they should be pretty close to each other. So if you don't have VQ mismatch, and I'll describe what that is in just a little bit. If you've got normal VQ matching, these should be 5 points or less from each other. So they should be pretty close to each other. And that's why we can use end-tidal CO2 as a surrogate, just to kind of tell us what's going on from a ventilation standpoint. So now if you want to get like really nerdy and like super geeky, one of the things we can talk about, now I will tell you clinically, we don't measure VQ ratios, but if you want to get super geeky and super technical, we'll talk about the VQ ratio. So ventilation, basically that's just what you're breathing in and out of your lungs every minute. So normal ventilation, or what we call minute ventilation, is about 4 liters a minute. Textbooks are going to say like 5 to 8 liters a minute, but in general, if you're resting, you're healthy, about 4 liters a minute is pretty normal. Now perfusion, that would be the blood reaching your alveoli, and a normal cardiac output, not index, but cardiac output's about 5 liters a minute. So if you look at the ratio between ventilation and perfusion, a normal ratio is about 0.8. So again, looking at VQ, so ventilation 4 liters a minute divided by perfusion 5 liters a minute, that ratio is about 0.8. And but we don't clinically use this because it's difficult to measure. That we can't measure minute ventilation in every patient, or for that point, we can't measure cardiac output in every single patient either. Now, VQ mismatch happens when you've got shunts. So basically, shunting is when you've got perfusion with decreased or no ventilation. So like a typical shunting, I'm just going to be current in what's happening in the world right now. You'll see shunting with COVID-19 with ARDS patients. They're getting a bilateral, basically non-cardiogenic pulmonary edema with infiltrates. Now, dead space is when you've got ventilation with decreased or lack of perfusion. A classic patient who's got lots of dead space is someone who's in cardiac arrest or someone with a pulmonary embolism. So those are conditions where you'd see VQ mismatching. So capnography is super easy to use, as you all have probably you understand, is you can use it with cannula devices. The devices with the reservoir are really important to use. Basically, that reservoir will sample CO2 wherever it identifies the kind of strongest flow, so either from the nose or mouth. The colorimeter devices or the CO2 change devices are used as just kind of a quick spot check to detect CO2 on intubation. But remember, again, the gold standard is continuous waveform capnography. You can use end-tidal with a BVM and ambu bag. So you would put the capnography sensor right in between your bag valve mask and your ambu bag. And then finally, you can absolutely use it with an endotracheal tube. And then probably this is where you're going to get your most clean sample, is when you've got an advanced airway with an endotracheal tube. So, so continuous waveform capnography, again, just remember a normal patient end-tidal CO2 is about 35 to 45. And just a reminder one more time, the PaCO2 and end-tidal should be less than 5 points from each other. couple things I just want to say, just to be Captain Obvious here, though. SpO2 is great. It's fine. It basically reflects the percentage of hemoglobin oxygenated with blood. Um, but I wanted to just be super clear to say this is a super late indicator. And unfortunately, I think EMS, so those of you who are on the line from EMS, you are probably light years in front of hospitals as far as utilization of capnography. I feel like hospitals still really lag behind in utilizing capnography, but SpO2 is a super late indicator. And I'm pretty blunt. I mean, a lot of you who know me know, like, I'll just kind of say it like it is. But when does SpO2 tell you you've gotten a patient who's in trouble? When it's too late. Oftentimes when it's too late. And then, but end-tidal CO2 is going to be a much earlier indicator of ineffective ventilation. So, that's why it's indicated if you're using procedural sedation, or, if you've got a patient who's on a ventilator. It's going to be a much, much earlier indicator to give us an indication if we've got some issues. So a couple things I want to talk about. So let's say, just because again, I want to just get a good baseline with everyone. So let's say you give me, let's say I'm a patient in your unit, and you give me, I don't know, let's say you give me some Dilaudid. I'll be honest, I've never taken an opioid in my life, so I'm opioid naive. So let's say you give me some Dilaudid. That's going to suppress my breathing, right? So that's going to suppress my breathing, and my end-tidal CO2 is going to go up. So here, sorry, I'm describing what's happening on the right side. So let's say, so we'll talk about on the right. So let's say you give me some Dilaudid, that's going to suppress my breathing, and my end-tidal is going to go up. The CO2 in my blood is going to increase. But let's say I come into your unit, or maybe I call EMS, and I'm working hard to breathe. So I'm air hungry. I'm working hard to breathe. I'm breathing fast. I'm blowing off my CO2. So my end-tidal CO2 as well as my PaCO2 will decrease in those situations. And again, that's if I have normal VQ relationships. So meaning that I don't have shunting and I don't have dead space. So again, I slow my breathing down because you've given me an opioid. My end-tidal CO2 is going to rise. I'm coming into your unit because I'm DKA, I'm breathing fast. My end-tidal CO2 is going to fall. So a couple things I think that are really good to know about a typical end-tidal CO2 waveform. So when we look here at like point A to point B, that's a point at which no CO2. So this is a classic like normal end-tidal CO2 waveform. When you look at point A and to point B, that's the baseline. So that's the point at which no CO2 is being exhaled. From point B to C, that's when you see those early rapid rises in early exhalation. And what you're seeing is an early rise in your patient's CO2. And that's when they're starting to clear a lot of their dead space. So from C to D, that's what we call the alveolar plateau. And that's when alveolar gas exchange is taking place. D is basically the end point of exhalation, and that's where your devices measure end-tidal CO2. And then the point from D to E is when your patient is inhaling, and that's when you see a rapid decrease of your CO2. So this is what a normal waveform looks like. A, B, and E should all come back to the same baseline. So a couple things. One of the things that always worries me is when people don't use end-tidal CO2, especially when they're transporting patients with an advanced airway, or if you're just not using end-tidal CO2 to verify placement. So remember, end-tidal CO2 will tell you if the tube is in the lungs versus the gut. A chest x-ray will be needed to tell you how high or how low that tube is, but end-tidal CO2 is the definitive to tell you whether your tube is in the lungs versus the gut. And I always worry again about patients transporting without end-tidal CO2. How do you know that your tube is still in the right place? I mean, you can visually look at it, see, what the exit measurement is at the mouth, but end-tidal is going to tell you right away if you've got a tube that's been displaced, and what you'll get is basically just like a flat line. Now, it was really interesting. So a couple years ago, think it was 2018, there were a few patients in the UK where end-tidal CO2 was not used in elective surgeries, and patients died that because they had esophageal intubation. And so the UK did this, I thought, brilliant educational launch. And one of the little sayings that they used was, if you use end-tidal CO2 and don't have a trace, your endotracheal tube is in the wrong place. So no trace, wrong place. You should be using end-tidal CO2 on every intubation to verify whether that tube is in the lungs versus the gut. So waveforms might change, and I'm sorry I didn't have a high resolution graphic on this, but you can see here. So how does this look a little bit different? Well, you don't have a nice even plateau. Basically, you see a rise in what should be a plateau right before end exhalation, and you'll see this. This is actually can be a good sign in a lot of patients. You'll see this if perfusion is improving. Or you have an increase in cardiac output. Maybe in hypermetabolic states, you might see this. But also, if you get sudden hypoventilation, you might observe kind of this increase in the plateau, which is a sign of increase in end-tidal CO2. So it can be a good sign, but it also can signal that maybe you've got partial airway obstruction, or again, you've got a patient who's suddenly hypoventilating. Now, the shark fin, I think, is super helpful. So how many of you have taken care of patients who have like a COPD exacerbation or maybe an asthma exacerbation? What you'll see classically in them, because of their airway restriction, is a shark fin type waveform. And what you'll note and observe is that as you give your beta agonist, like albuterol, is you'll see this start to plateau out. And so I really think capnography can be super helpful, especially in patients who have COPD and asthma exacerbations. Also, it can, if you've got a kinked ET tube, endotracheal tube, you'll see this waveform as well, or really any partial airway obstructions, you'll see a change in your waveform. Now, a downward slope during the alveolar plateau, you can observe in severe emphysema. So just a couple things to really be aware of. Another thing you might see that is it's a sign that you need to recalibrate your end-tidal CO2 device is if you see drift or increase from the baseline. So with every breath, it should come down to the baseline. So if you're seeing, an increase from the baseline, that's a sign that you really should calibrate your device, or it could be a contaminated sensor as well. So as end-tidal CO2 and SpO2 they're both important, but they measure two really different things. So remember, capnography reflects ventilation, whereas SpO2 just represents oxygenation. And there's going to be a major lag time with hypoventilation and apnea just using capnography. And this was an early study. And again, a lot of people, you have to understand studies in general. So there is so much literature that was published in the 90s and early 2000s really supporting capnography. So a lot of times I will reference older studies, and nurses will say, that study is so old. Well, here's the deal, guys. You can't keep studying what we know over and over and over again. So if you see older studies referenced in capnography, it's because it's been proven. So we're not going to keep studying something that's been proven. But a really interesting study from 2007 just indicated that respiratory depression was 28 times more likely to be detected from end-tidal versus SpO2. So really, in high-risk patients, you should be considering end-tidal CO2 in addition to SpO2. All right, so I have to say, I show this with caution, but I just feel right now in healthcare, we all need a good laugh. I don't know about you guys, but I know, a lot of us are feeling super stressed out who work in healthcare. But so just please don't be offended by this. This is meant for a laugh. So a lot of you, and it's not a laugh in that, in how this came to be, but it's how what came to be. So anyway, so you all know how Michael Jackson died. So he died of respiratory depression. He had a respiratory arrest that led to cardiopulmonary arrest from using propofol to sleep. And all of the EMS crew that responded to Michael Jackson's house had to testify in court as to what they saw. So the medic was on the witness. One of the medics who responded to the scene was on the witness stand. And the court reporter, so if have you ever done jury duty, the court reporter kind of sits there and does the court reporting on what's being said. So the court reporter, so what the medic was saying was that the capnography was really low. It was 16. But what the court reporter heard was that the cap pornography reading was low. It was only 16. So anyway, again, don't take offense to this, but right now I feel like we all need a laugh in healthcare. So anyway, so I'm sure a lot of us will never look at capnography the same again. So why use capnography? So this is a case of a woman, a young woman named Amanda, but she was admitted to the hospital with severe pain. She had a strep throat infection, and she was admitted. Now this is 10 years ago, but was admitted on July 15th. And I share this case. I know it's older, but it was public, and her family wants this story to be shared. She was admitted to the hospital for severe sore throat. So initially they were using oral analgesics, but that wasn't relieving pain. And, during this time, a lot of hospitals were there was reimbursement that was tied to how patients rated their pain scores. So you wanted to make sure everyone was free of pain, right? But I think to a detriment of patients. And so she was admitted on a Thursday. The next day they put her on a PCA pump with opioids. And one of the things I just have to say is I think something we can do, we want to relieve patients' pain. So don't get me wrong, but sometimes I just think we need to say it's going to hurt. Here's where we're going to try to get your pain level, but you're going to have some pain. We're going to try to manage it as best we can. But they put somebody with strep throat on a PCA pump with opioids on a Friday evening. By the next morning, she was found unresponsive and unfortunately died after being, attempted resuscitation from cardiac arrest. So, we have to be careful. In so many hospitals, especially, are using SpO2 to monitor patients, and they're using it intermittently, who are getting opioids. So, I'm so concerned about this. Really, we should be using capnography. And really, and now a lot of so this would be more geared toward hospitals, but a lot of that new generation PCA pumps are now starting to be sold with capnography. That's how important this is. So, anyone who's run a code blue team, me included, have files of patients who have died from PCA pumps. So again, you've got to use the right technology. Now, how many of you have ever dealt with somebody who has had maybe alcohol poisoning or heroin overdoses, things like that? This is where I find capnography to be really, really helpful when you've got patients with different respiratory suppressing drug ingestions or overdoses. Capnography, again, you can look at a patient, you kind of look at it and be like, not really sure they're breathing okay. Well, capnography is going to give you a really good indication, of the point. Do you need to give Narcan? Do you need to provide an advanced airway? Because remember, Narcan shouldn't be given just for decreased level of consciousness. Narcan really should be used like in heroin overdoses or opioid overdoses if you've got respiratory suppression. So it can be super helpful. All right, here's our first case. So we've got a 32-year-old who EMS brought to the emergency department. The patient's roommate told EMS that she had altered mental status changes and wasn't acting right. So vital signs as EMS brought the patient to the hospital: heart rate was 136. Blood pressure was 108/54. She was breathing 42 breaths a minute with a fruity odor. So I'll know where I'm going with this, right? So her SpO2 was 93%, and EMS luckily put an end-tidal CO2 monitor on the patient, and her end tidal was 14. So the other thing that was noted at the time was that the patient had a medical alert band that said she was a type 2 diabetic. So why is her end tidal CO2 only 14? Well, it's because she's breathing 42 a minute. So she's Kussmaul breathing, blowing off her CO2. So one of the things that's happening now is a lot of EMS agencies and emergency departments are using end tidal CO2 as kind of a surrogate to kind of managing ketone production and ketoacidosis and basically anion gap. And as you close the gap by giving fluids, by administering insulin, as you close the gap, you should see the end tidal CO2 rise in these patients as their breathing slows down. So next step, so they checked a glucose. So the medics had actually checked a glucose and it was reading high. So priorities, obviously this patient needs an IV, fluids, insulin. And one of the things providers will do is they'll calculate using, if there's a calculation you can do that calculates a patient's fluid deficit. So you want to get fluids started. But the patient was really resisting. She was giving EMS a really hard time. And now she's in the emergency department and they're allowing you to start treatment. So they got a liter of lactated ringers in, started an insulin infusion. Heart rate's 128 now, blood pressure is 112/56. Her respiratory rate is now down to 38. SpO2 is 94%. Her end tidal is now 20. So it went from 14 to 20 after fluid and insulin. So you can see we're heading in the right direction because we're starting to close her gap a little bit. So now her glucose is 480 with a K of 5.8. Sodium's 128 and she's got an anion gap of 24. So normal anion gap is about 11 to 12. Normal sodium would be like usually about 136 or higher. Her K is 5.8, which actually I'm really happy about that because now as soon as we start insulin, the insulin's going to drive that potassium back into the cell. She's got ketones in her urine and blood, which is no big surprise. So they decide to give her another liter of lactated ringers. They get insulin started. Now her heart rate's down to 125. Blood pressure's holding pretty tight. End tidal's 24. So you can see now the end tidal is just gradually coming back up as she's getting fluid and insulin. So 2 hours later, they repeat her glucose. So now it's 246. So now what we worry about is she needs to get some sort of dextrose in her IV fluids so we don't make her hypoglycemic. Her K is down to 5.2 because the insulin's pushing it back into the cell. Her sodium's coming up and her gap is now down to 17. So now she's gotten a total of 4 liters of fluid, and you can see her end tidal is now up to 31. So this all happened over a period of about 6 hours, but you can see how end tidal was super helpful in this case, as just it trended in an upward direction, indicating that we were closing the gap, and her Kussmaul breathing was ceasing. So there's lots of different metabolic emergencies that you can consider end tidal CO2. So DKA is a case like I just described. Seizures, I will tell you, it's really difficult to tell if a patient is ventilating appropriately when they're having a seizure. This is where capnography can be really helpful. Sepsis, and I'm actually going to show you guys a sepsis case in just a little bit, but there's different cardiovascular emergencies where capnography can be very helpful. So in pulmonary edema from heart failure, acute MIs, again, but I'm going to talk about VQ mismatch. So I would say just everything I'm listing on the right side, you're going to see with it's really helpful to understand VQ mismatch. So I'll come back to all of this, but pulmonary embolism is a big one as well. So those again would be all VQ mismatch, which I'm going to talk about in a minute. So can you use capnography to predict sepsis? So this was really interesting. So as EMS brought patients to the emergency department, so this was a study that was conducted in 2 different emergency departments. And in triage, what they would do is if the patient met at least 2 or more SIRS criteria, which you all know is a heart rate that's a little faster, respiratory rate that's above that's a little faster. If their white count was elevated or low, or if they had a temperature that was either high or low, they would add capnography to these patients. So again, just to reiterate, 2 SIRS criteria plus a suspicion of infection, they would add capno. And what they found was when the capno was less than 25, so I want you to think about this, normal's 35 to 45, if the capno is less than 25, how is the patient breathing? And we all know the answer is fast, right? They're breathing fast. So if the CAPNO was less than 25 with 2 or more SIRS criteria with a suspicion of infection, they would activate a sepsis alert. So how predictive was 2 SIRS or more plus a CAPNO of less than 25 plus suspicion of infection in identifying sepsis? And it scored an area under the curve of a 0.99, meaning it got it right 99% of the time, which is pretty freaking amazing if you look at the statistics behind that. Now, I will tell you, this was a small study. I really do hope that this study gets replicated on a much larger level, because the problem in hospitals and with EMS agencies is often we don't measure the respiratory rate, we make it up, right? And so some of you might be getting mad at me right now for saying that, but let's just be honest. My 16 was my number. If I was mildly concerned about you, you got a 24, and if I was really concerned, you got a 32, right? And it's a super well-known thing. We make up the respiratory rate in healthcare, unless we're concerned, and a lot of times then we'll measure it. But I think this is really telling, that they're breathing fast when they've got sepsis. They're not necessarily dyspneic, but they're often tachypnic, meaning they're silently breathing fast. All right, so those were all situations with VQ matching, meaning your end tidal CO2 is going to be very reflective of what you measure in the blood. Now we're going to talk about situations where you've got VQ mismatch. So why does capnography reflect perfusion? We know it's a good reflection of ventilation, but it also can be a really good reflection of perfusion, and I'll just say metabolism as well, but let's stick with perfusion. So one of the things we know is as your cardiac output drops, there's less circulation of CO2 to bring it back to the lungs. So less CO2 is going to return. Thus, patient will exhale less CO2. And so again, when your cardiac output drops, your end tidal CO2 is going to drop because there's impaired transport of CO2. So it can be actually really helpful to use capnography in low cardiac output states as a gauge of just kind of measuring, are my interventions improving perfusion, which will lead to an increase in the end tidal CO2. And that's why it's used in cardiac arrest. That's why it's used in low cardiac output states. Let me show you a case in sepsis. So this was a patient I took care of that was septic. She was on a ventilator. She had pneumonia, and she had gotten like 6 liters of fluid. So she was 63, had gotten 6 liters of lactated ringers, was intubated, and then she dropped her pressure. So her urine output had dropped, and then she dropped her blood pressure. So can we all agree, low urine output, a pressure of 84/42 with a MAP of 61, we probably need to do something, right? So anyway, I didn't really have anything that was predictive of whether she'd be a fluid responder. So you can see her heart rate's only 89. Well, that was because she was on a beta blocker prior to coming to the hospital. Um, so I didn't really have anything. So what I did was I connected capnography, because I'm trying to decide, I've got a low pressure. She's already gotten 6 liters of fluid. I don't want to pound her with more fluid if she doesn't need it, right? Because I don't want her going into ARDS. So I'm trying to decide fluid pressure, which way do we go? And so what I did was I hooked capnography and did a passive leg raise test with her. So with her head of the bed, so I connected the capnography, got a baseline. With her head of the bed up 45 degrees and her legs straight, got a baseline end tidal CO2. And then what I did was I dropped her head and lifted her legs, and I watched what her end tidal CO2 did by lifting her legs. So by lifting her legs, you're taking that blood from her legs and lower abdomen, and you're pushing it back toward the heart, and you're identifying what is her heart doing with this air quote fluid challenge. So I'm challenging her heart with the blood volume in her legs and lower abdomen. A lot of the literature equates that to about the equivalent of a 300 cc fluid bolus. And you want to leave the legs elevated for about 1 minute to 2 minutes, and then reevaluate to see what does her end tidal CO2 do in response, or if you have a stroke volume measure, what does her stroke volume do when you lift her legs? And so so who wouldn't you do this passive leg raise test? And if you've got somebody who's got, you want to take off any venous compression stockings, you want, if they've got lower extremity DVT, this is probably not the test to do in them. If they've got ICP, intracranial pressure issues, this isn't the test for them. And if they've got an amputated leg, I mean, it kind of goes without saying, this is probably not the test for them. So, but anyway, so what I did was, with her head of the bed lifted and her legs straight, her capno was 29. And I'm looking at her capno going 29. I'm like, okay, let's see, she's breathing 16 with the ventilator. This doesn't make sense. But then I'm like, maybe she's got VQ mismatch, meaning her end tidal has dropped because her cardiac output has dropped. So then what I did, I took a picture of it because I'm like, I knew the the attending I was working with was not going to believe me. So anyway, he's kind of a naysayer. But anyway, so again, head of the bed lifted, head of the bed up, leg straight, got a baseline. It was 29. So then I dropped her head and lifted her legs. And no joke, I took a picture of this because I'm like, oh my gosh, she needs fluid. I lifted her legs, and after 1 minute, she showed 36. So 36 was her end tidal CO2. So what does that mean? Well, that means by lifting her legs and challenging her heart actually responded in a positive way. And that's a sign that she's going to be fluid responsive. So we gave her fluid. Now, what this test doesn't tell you is how much fluid to give, right? But so we were kind of gentle with her because she had already gotten 6 liters of fluid. So we just gave her a little tinge of fluid. I think I gave her, I want to say 250 cc's at that point. But Xavier Monet, who's absolutely amazing, so he's an intensivist from Europe, has published quite a bit on using end tidal CO2 and stroke volume with the passive leg raise test to identify fluid responsiveness. But in this study, this was a study in intubated patients, and what he was able to identify is if your end tidal CO2 goes up by 5% or more, that with the passive leg raise test, that's an indication that you'll likely be fluid responsive. And just kind of outlined everything in his study here, but really interesting what he found, because they looked at heart rate and blood pressure as indicators of fluid responsiveness, and found that like a fast heart rate and a fast heart rate and a low blood pressure, those were not indicators of fluid responsiveness. So here was my patient. So we gave her a little tinge of fluid. So 4 hours later, she drops her blood pressure to 84/42. So her capno baseline, so I did, again, got a new baseline, head of the bed up, 45, legs straight, was 34. So then I dropped her head and lifted her legs, and it went to 33. So it actually went down, which was kind of concerning to me, because now I'm thinking, am I stressing her heart now? So I'm not going to give more fluids now for the second episode of hypotension. What am I going to do? I'm going to restart her norepi infusion. So she had been on norepinephrine or Levophed during the night shift, and night shift had turned it off in the morning. And she just needed her norepi restarted. So, and it kind of makes sense, right? So she's septic, she's got a pneumonia, her blood vessels are vasodilating, and norepinephrine was a very logical thing to restart at that point. So how predictive is end tidal CO2 to tell you if your patient will be a fluid responder? And it squares an area under the curve of 0.93, meaning it's going to get it right 93% of the time. You can see arterial blood pressure scores an area under the curve of a 0.65, which means there is a huge margin of error, and you really should not be using blood pressure to decide if your patient needs fluid. So, so really interesting stuff. All right, let's talk about cardiac arrest. So the AHA and the International Liaison Committee on Resuscitation have both recommended capnography to verify endotracheal tube placement. So we all should be doing that. And again, one more reminder, a normal is 35 to 45. So during cardiac arrest, so let's just chat about this really quick. How many breaths? So let's say you've got a patient who has an advanced airway and you're ventilating that patient. How many breaths should you give per minute? The answer is it's 1 breath every 6 seconds. So that's a really slow ventilation rate, right? So, but what are we seeing in codes? And I'll tell you what we're seeing in codes is we are seeing that we ventilate way too fast. So this is actually from a real cardiac arrest, and this was using a CodeStat, which is a software program that you can use. Every defibrillator has a way to kind of create a post-event CPR report card. But you can kind of see here, this was quite alarming. They were giving breaths 41 a minute, 45 a minute. All these little blue triangles are a breath. 49 a minute, 51 a minute, 55 a minute. This is insane. What's the problem in cardiac arrest with ventilating too fast? Well, so I wanted you to imagine you're breathing for these patients. When you do that, when you hyperventilate, it increases intrathoracic chest pressure, which is going to collapse the IVC, which will decrease venous return, which will have a massive impact on your CPR quality. So, the ventilation rate should be super slow. Now, I'm going to go backward here just a little bit. And just say, your goal with compressions is an end tidal of at least 10. And I'm going to talk about some pointers on that. But one of the things I think that end tidal I have seen clinically is super helpful with is when you have return of spontaneous circulation. So I have seen so many patients who we get ROSC, and you'll see just all that CO2, now that their heart is beating and contracting on its own, you'll see a lot of that CO2 mobilized and transported to the lungs, and you'll be able to measure that on end tidal. And it's nothing to see a big, huge increase in your end tidal CO2. I mean, every patient's gonna be a little bit different, but I've seen some patients have end tidals in the 70s and 80s once we get their pulse back. So this is a super interesting story. This was out of Minnesota, but this was a patient or a person who had arrested. He was 54 years old, had arrested at one of the local grocery stores. 911 was called. The patient got bystander CPR. They attached an AED, and the patient was in VFib. And the patient had got multiple shocks at the scene, and then they decided to transport. They did air transport to Mayo Clinic. So Mayo flight crew got the patient transported to Mayo, and they resuscitate this patient for 96 minutes. So it was really interesting when the EMS crew was interviewed after this arrest. They asked, why did you keep going? They went 96 minutes on this patient. And what one of the flight paramedics said is if they didn't have the CO2 readings they were getting, which were consistently in the 30s during his arrest, if they didn't have the CO2 readings they were getting, they would have terminated efforts much sooner. And so, again, I think this is end tidal can be really helpful to say, if you've got somebody who's in cardiac arrest and they've got end tidals that are decent, keep going. Ask, what is the endpoint of resuscitation? And I'll tell you, for a lot of VFib arrest patients, it's in the cath lab, artery open. So, it can be super helpful in those cases. So let me, I'm going to demonstrate, give you guys another case that I was involved in. So this is a 38-year-old who was in PEA arrest for over 20 minutes after a suspected heroin overdose. Narcan was administered. We've got ongoing chest compressions. So EMS brought the patient into the emergency department. A patient got intubated without incidents, and the capnography was reading 24 with chest compressions. So what do you guys think about 24? I'm thinking, like, awesome, keep up the work. We're doing a really good job, right? So during the codes, this is in the emergency department, we get a blood gas, and someone comes in and proudly reads the blood gas, and they're like, the pH is 718, the PaCO2 is 82, the PO2 is 106, bicarb 26. You can see the numbers there, obviously, right? But what was really interesting was the provider leading the code instructed the respiratory therapist to ventilate the patient faster to blow off the CO2. Why did they say that? Because the PaCO2 was 82. I don't know. What do you guys think? Patients in cardiac arrest, ongoing chest compressions. We have a capnography that's reading 24, a PaCO2 that's reading 82. Should the respiratory therapist bag faster to blow off the CO2? And the answer is no, don't do that, right? So we have VQ mismatch here. So the PaCO2 is 82. but the end title is 24. Why is there such a big discrepancy? Well, because the patient's in cardiac arrest. So this is classic VQ mismatch. Your blood CO2 is going to rise while your end title falls. And, and you've just got to really, really just understand now is not the time while you're doing chest compressions to fix the PaCO2. When you get ROSC, that's the time to again worry about what that blood gas CO2 is saying. All right, here's our next case. We've got a 52-year-old who goes into VFib. We get chest compression started. They get shocked. We do a couple shocks. They get epi. The patient gets intubated. We're breathing, giving one breath every 6 seconds. The waveform capnography was reading 20. So what do you guys think about 20? I'm thinking 20 looks good. Keep going, right? Okay. All right, so we keep going. After 4 minutes, the rhythm is assessed, patient still in VFib, we shock again, a new provider starts compressions. The capnography is now reading 9. What do you guys think? We had 20s, now we're at 9. So we coached the person, so the person giving compressions, coached them and said, you try to go a little deeper, looked at hand placement, looked at their body position, gave them a step stool to get their shoulders over the patient's sternum. And interesting, it was still low. It was still, so what do you do now? And I have to say, this is the point at which, we probably should change providers. I will just be super honest. It was a female who, was very small statured. So we changed compressors. And I think it was absolutely appropriate in this case. So now we're 7 minutes into the arrest. The capnography is now reading 38. So we got a new provider. We're quite a few minutes later. The capno is now reading 38. So what do you guys think? I'm thinking maybe we have return of spontaneous circulation, right? So maybe, but we're 1 minute into this cycle. So should we stop or should we keep going? And I think most of us would agree. Let's keep going. Let's go ahead and just kind of keep going here to the end of our 2-minute cycle, and then let's assess for a pulse. So at the end of 2 minutes, there is a pulse. The capnography is now reading 34. So one of the things I can't stress enough for EMS providers as well as hospital providers, keep the capnography connected to these patients when you get return of spontaneous circulation. So airway gets established, patients brought to the hospital, capnography has trended from 34 to 26. So the capnography is trending downwards. So what do you guys think about that? I'm thinking they're hypoperfused. And I'll tell you, a lot of times you'll see if a patient's hypoperfused post-arrest, you'll see this capno drop way before you'll see a blood pressure drop. And so we did the passive leg raise with the patient once they got to the hospital, and it went from 26 to 30. So is that at least a 5% increase? The answer is yes. So that's an indication that maybe the patient will be, not say maybe, likely, the patient's going to be responsive to fluid. So, using capnography in the post-arrest phase can be super duper helpful as well to identify early signs of hypoperfusion. So again, if you see a downward trend once you get return of spontaneous circulation, that could signify low perfusion and might be a warning sign that your patient is going to rearrest. So now the last case I'm going to talk about with VQ mismatch is a patient who was at home. So was really interesting. So 49-year-old patient who had a bowel resection surgery a week ago was discharged home. She had a known DVT, was on home Lovenox. So the husband calls 911 because she's complaining of shortness of breath. So they apply oxygen, and her oxygen needs are very, very quickly increasing. So her heart rate's 122, blood pressure is 92/46, so a little bit concerning. Breathing 38 a minute, very concerning. Her capnography is reading 12. Now, I think we can all agree a capno of 12 in somebody who's at home, who's got a DVT, this is not good, right? So this is not good. I'm really wondering if she's got massive dead space because she has what? a pulmonary embolism. Anyone who's got a DVT that gets short of breath, you right away have got to have PE very high on your radar. So O2 stats are dropping with EMS. She's in the 80s. She's on 100% non-rebreather mask, and she says to the team that she feels like she's going to die. And I don't know about you guys, but when a patient says to me they feel like they're going to die, I believe them, because what usually happens, they die. So that impending feeling of doom is real, especially in pulmonary embolism. So they so what they do is they get a 12 lead, because again, it's hard, to say what exactly is your differential, but they get a 12 lead. And a couple things that are really interesting here. So in with PEs, something we'll see is what's, you don't always see this, but if you do see this, it can kind of lead you down the PE pathway. But they get what's called an S1Q3 T3 changes on their 12 lead. So in lead one, you'll see this real hugely prominent S wave. So you can kind of see that there in lead one. And then in lead three, they often can get Q waves. So she's definitely got major Q waves there. And then she also developed a right bundle branch block acutely that was not known on there was no ever mention of her ever having a bundle branch block. So very concerning. So these are all signs of, that can be consistent with a PE or cor pulmonale, where basically you've got really high pressure on the right side of the heart and the right ventricle is dilating. And this is a huge sign of right ventricular strain. So unfortunately, she ended up going into PEA arrest. Chest compressions got started. Your differential, I've already kind of mentioned it, but we're thinking PE here. So we're thinking this is a pulmonary embolism. So she gets transferred to the hospital. CPR is in progress. They decide to do recombinant TPA, so they 90 milligrams was ordered and given, and they were able to get her intubated without interrupting compressions. Now her end tidal is reading 8. So what do you guys think? She's got chest compressions ongoing. Should we kick the person off the chest who's doing compressions? No, I don't think so. Because basically she's got massive VQ mismatch because of a blood clot in her lungs, right? And so her CPR quality was incredible. Why is it only reading 8? Because she's got massive dead space, or basically air that's not taking part in gas exchange, because she's got a massive pulmonary embolism. And so she's got big VQ mismatch. So she's got ventilation without perfusion because of dead space. Now, what's going to happen to the PaCO2? So if you were to do a blood gas, what will happen to the PaCO2? It's going to rise. So she's going to have a majorly elevated PaCO2. So with PEs, there's lots of dead space. And remember, again, dead space is just the volume of air inhaled that doesn't take part in gas exchange. So there's a calculation we can do. It's called the dead space calculation. But basically, it's your PaCO2 minus your end tidal divided by your PaCO2. I know clinically we call this PECO minus PECO divided by PECO. And if the dead space calculation is less than 30%, it's not a PE, and it has 100% negative predicted value. But if it's above 30%, this could be consistent with a pulmonary embolism. And so let me just kind of walk you through her case, and then we're going to take questions. So get your questions submitted to Kim, and then I'll take your questions because we're ready to wrap this up. But so her end tidal was up to 11, and that's the point that we got return of spontaneous circulation. So the TPA had gotten started. So 2 hours later, her end tidal was 15. Her PaCO2 is 56. So is there a VQ mismatch? The answer is yes, and we expect it, right? She's got a pulmonary embolism. She's still on 100% oxygen at this point. So we did the dead space calculation, which remember again is PECO minus PECO divided by PECO, and her dead space was 73%. So that's pretty consistent with a pulmonary embolism. So 6 hours later, her end tidal was 24. So are we heading in the right direction? Yes. Her PaCO2 is now down to 48%, and her oxygen needs are decreasing. So now her dead space is 50%. So we're definitely heading in the right direction. 12 hours later, her end tidal is 30. So are we heading in the right direction? Yes, her PaCO2 is 40 and her oxygen needs are decreasing. So her dead space is 25% now. So prognosis, so luckily she did well. The TPA, lysoclot. One of the other therapies a lot of us are using now is we're using the ECOS catheter. So it's EKOS, ECOS, and we're threading these catheters through the pulmonary embolism and administering TPA from the inside of the clot to lyse it from the inside out. And these catheters do an ultrasonic vibration that helps to distribute the TPA in the middle of the clot. And the really nice thing about the ECOS catheters, you can use as little as 4 to 24 milligrams of TPA, which will decrease your bleeding risk. So just to kind of wrap things up, capnography can be super helpful. You just have to understand, if patients have VQ mismatch, the end tidal CO2 is not going to be the same as the PaCO2, but it is a class 1 recommendation to use end tidal with continuous waveform capnography to verify ET2 placement. You can use it as an indicator of ROSC, and that's where I find it to be super helpful. You can use it as a measure of CPR quality, but you just have to be understanding and knowing if the patient has something that alters perfusion like a PE, you're not going to get a number that's reflective of your CPR quality. So you just have to understand the limitations of it. You can also use end tidal, if you've got a patient who's in, like, let's say asystolic arrest, and you've done everything. You've marched through your 5H's, 5T's. You've tried to identify reversible causes, and you can't identify anything that's reversible. If your end tidal is still less than 10, then you can use that number to discuss failure of resuscitation and stopping efforts. And then just remember, do not overventilate these patients, and capnography can be super helpful in giving you the number of times you're ventilating a patient. So just, again, just understand its limitations. So in conclusion, again, use capnography. It can be super helpful in ventilation, VQ match or mismatch, fluid responsiveness, CPR quality, and then of course return of spontaneous circulation. So with that, I'm going to hand it over to the most awesome Kimberly Kelly, who is going to take your questions, but she's also going to give you some information about how to get your CE. So Kim, I'm handing it over to you.
Thank you, Nicole. That was a really great informative session. I learned a lot on top of it. Before we begin our question and answer session, I do have a few reminders for the audience. Continuing education for nurses, respiratory therapists, and EMS professionals. This activity has been approved for 1 contact hour. You're going to want to go to saxtesting.com/SL. You will need to register on the test site and complete the evaluation form. And then upon successful submission, the respiratory therapists and nurses will be able to print out your certificate of completion. And for EMS professionals, your certificate of completion will be emailed to you. An on-demand or archive version will be available on savinglivesnow.org. An email will be sent to all registrants when it's available, and the on-demand version will be accredited for nurses and respiratory therapists. So we're going to get this question and answer session started here. There have actually been some really great questions coming out of it. The first one I want to start with is from Angela. Can you please address the very common waveform seen with opioid administration? Hypoxic hypoventilation, shallow breathing, dead space mostly, where end tidal CO2 reads are very low, but the PaCO2 is climbing.
Okay, Kim, I'm sorry. Can you repeat the first part of the question? So
No
just say it
problem.
again. Yeah, I just want to make sure I'm understanding the question correctly.
Absolutely. No, she is asking, can you please address the very common waveform seen with opioid administration, hypoxic hypoventilation?
I'm not really sure what she's asking. I mean,
she said shallow breathing with like dead space mostly, where the end tidal reads very low, but the PaCO2 is climbing.
Well, that's a case of EQ mismatch then. So then I would wonder, do they have a decreasing cardiac output? Um, yeah, because if their cardiac output is stable, there's not hemodynamic compromise, there's no reason to think that the end tidal should be different than the PaCO2. So if you've got an end tidal that's dropping with a PaCO2 that's climbing, that's VQ mismatch, and you have to wonder if they're getting adequately perfused. So thank you. Sorry, I just needed to hear that a couple times. I thank you. It wasn't the way whoever submitted that, it wasn't the way I just had to hear it a couple times. So yeah, so that would lead me to think that they've got basically decreasing perfusion.
Yeah, yeah, no, and that was partially my fault because I messed up that word. Next question from Luke. What are your thoughts on CO2 narcosis and capnography? Are values going to alter in terms of VQ mismatch?
Sorry, I just hit the computer screen. Can you say it again? I'm sorry, you guys. Oh my gosh, I hit the computer screen and I
No,
got like
that's
in a
okay.
swirl. Okay, so say it again. Sorry.
No, you're fine. So this is coming from Luke. What are your thoughts on CO2 narcosis and capnography? Are the values
Yeah,
going to
yeah.
be altered in terms of VQ mismatch?
Yeah, so here's the deal. Okay, so here's the deal. If your end tidal is high, your PaCO2 is high. If your end tidal is low, who knows what your PaCO2 is, right? And it can be super helpful in CO2 narcosis. Yeah, I think that's a great question. Yeah, it can be super helpful. So if your end tidal is low, then your PaCO2 has to be at least that, but if it's high, your PaCO2 is at least that as well, right? So I don't know. I think it can be super helpful.
I agree. Catherine has another question. What is the recommendation for monitoring end tidal CO2 for intubated patients during an MRI?
Oh, during an MRI, I don't, I'm not sure. I think a lot of hospitals have their own policies around this. I mean, it's the safest thing to do, right? And in MRI testing sites, in the MRI rooms, everyone's got different equipment, but I would say if you can do it, you should do it. Absolutely. The only recommendation I know that's formal is from the American Society of Anesthesiologists, where they say if you're mixing opioids, so basically if you're doing procedural sedation, you should be using capnography. And I'll tell you, the patients getting procedural sedation are high risk, and you absolutely should be using capnography in those patients.
Yes, no, it's a high risk population, certainly. Carl has a question. While on the topic of cardiac arrest, while we were talking about it, have you found any recent updates regarding apneic oxygenation and delayed defibrillation? This person's also particularly interested in reliability of end tidal using the standard cannula setup versus inline.
Yeah, so a couple things. Okay, so first of all, I I'm not I don't know of any studies on delayed defibrillation. There's so much data to say get patients defibrillated as quickly as possible. Um, I will tell you, in most studies that have been done evaluating capnography, it's on the intubated patient. Have we used cannula devices in non-intubated patients? All the time. But most of the research comes from intubated patients.
We're going to take one more question just because we have run over time. This one is going to come from Eric. How do you change an institutional culture towards universal end tidal CO2?
Yeah, I know. I think that's a great question. And I think one thing is get your respiratory therapist involved. So if I'm assuming you're talking about in hospital, get your respiratory therapist involved. Get them on board, see where they are with things. Most new generation ventilators are being sold with capnography. I would not, there's no way I would buy a defibrillator now without having capnography capabilities. But I would tack it from a multi-pronged approach. I will tell you, EMS bringing patients into hospitals with capnography has driven increased capnography utilization. I would understand like what are your EMS agencies doing? Find out what the ED is doing. I find that the ED most EDs are higher users of capnography than hospitals. I would also check in with your intensivist team. Find out what's the reason we're not doing this. I would also look to people like patient safety or people who run your code blue committees, because they know if you've had instances in your hospital where patients had respiratory that led to cardiopulmonary arrest from respiratory depressants. I would also talk to risk management and find risk management of all people knows these cases. So I don't know, like I think you really need to take a multi-pronged approach in getting it implemented. But I really do think top notch, your respiratory therapists have got to be driving a lot of this change.
That is all the questions we have for today. Thank you so much,
Perfect.
Nicole.
All
I'm
right,
going
thanks
to
to
turn this back
everybody.
over to Tracy.
Okay, thank you guys.
We'd like to thank everyone for attending today's webinar. And immediately upon the conclusion of this webinar, you'll be presented with an online survey. Please keep your web browser open, and please let us know if you participated in a group and if how many people were in that group. We thank you for our feedback. For your CE certificate of completion, in 1 hour following the conclusion of this webinar, you will receive an email with instructions in this link to obtain your CE credits, saxtesting.com/SL. And on behalf of SACS Healthcare Communication and our presenters today, thanks for joining us and have a great rest of your day.